donor lunch and learn this afternoon. A few housekeeping items before we get started. I'm going to go ahead and mute everyone just to keep the feedback from interrupting the presentation. So also we'll be using the chat feature. If you have questions that you would like to present to the administrative team or Dr. Lombard along the way, you can feel free to submit those in the chat room, and I will be happy to pose those questions when the presentation is over. So today we have with us Terry Weiss, CEO, Judy Newland, COO, and Incline Administrator as well, and Dr. Tim Lombard, who is our internist and cardiologist at the Tahoe Forest Health System. We'd really like to extend our gratitude for all of your support and your partnership, especially as we've navigated the last 8 months through this pandemic. These donor lunch and learns are very informative and educational and intended to be helpful as you work your way through each day during this COVID-19 epidemic. So the structure of today's lunch and learn will be, we'll have a brief update from leadership, followed by a 20-minute presentation or thereabouts by Dr. Lombard, and he'll be discussing the differences between COVID-19 and the seasonal flu. And it should be very informative. He's got a PowerPoint that looks very impactful. Following that presentation, we'll have time for questions and answers. So you can feel free to submit those in the chat room at any time, but I'll try not to interrupt Dr. Lombard and pose those questions towards the end of the presentation. So all in all, probably about 40-45 minutes together, and we hope that you enjoy the presentations. Harry, would you like to kick us off and get us started?
Sure. Good afternoon, everyone, and thanks for spending some time with us. Our healthcare team has been quite busy for a little over 9 months now, and that's really new to healthcare workers all across America because there's never been a disease with this level of energy that has persisted this long for nearly 100 years or so. And so I really applaud our team and all the other first responders and so forth out there that have been really busy at this, 7 days a week, 24 hours a day. They're humans, they're very courageous, but I know it's very tiring. We're hopeful that we're slightly more than halfway through this journey, as I shared in a meeting this morning, with some of the new tools we have in our toolbox. If we can really use all of them aggressively and thoughtfully over especially the months of January through August, I'm hopeful that we can greatly dissipate the energy that this disease has. Again, that's my subjective estimate, so if it doesn't turn out quite that way, I'll be the first to admit I was wrong a little bit there, but I think it's possible with the level of tools and vaccines and so forth and public health effort that we can put in place. We have seen in the last 3 weeks, in contrast to about 8.5 months, a surge in weekly positive COVID-19 lab tests that fluctuates a little bit every day, but I would estimate it's between 6 and 10 times what the weekly positive lab test results were for the first 8.5 months. So a very significant new phase. And again, it predated Thanksgiving. We're now getting out from the Thanksgiving period of, quite a number of days. I think we're going to watch and see whether we see an additional surge. Statistically, on our inpatient census side, I'm happy to see that our peak was a few days ago, and I hope that peak wasn't breached. We had run probably 6 to 7 on just single days as inpatients during the months of March through November, and then we jumped up and hit 10 and 11 in November and December, and we've had no days at 0 inpatients for probably the last 2 to 3 weeks. And in contrast, we had many days at 0 between the middle of July and around the 1st of November. So again, our team's been doing a great job. We've tried to really make sure that we have access to the best therapeutics, and that list has been growing, and also adding to our lab pieces of equipment and so forth, and others can share some of the details on that. And our next really big event as a health system is to really work in partnership with several communities and at least 3 counties, Washoe, Placer, and Nevada County, for probably the largest public health effort we've ever undertaken in the last 100 years. We're only 71 years of age, and that would be to do something very thoughtful relative to the vaccine for those that want it. And so we've got a lot of work planned for that. So we're pleased that we've recovered quite a bit financially from the very tough months of March, April, and May. We still have, a huge challenge, with unknown expenses and volumes and state and federal regulations that we have to monitor every day, and that could throw curveballs at us on any given week. And certainly the higher pace of testing has increased the state controls on many geographic areas as well. And so we're very concerned about families, we're concerned about businesses, small and large, and certainly our thoughts go out to all of those who are really struggling at this time as well. And we're just, as a health system, we're really focused on the mental health issues, the physical health issues, and encouraging our team and everyone just to take it one day at a time. We will successfully get through this, and we'll be free and healthy again if we all work together on this, hopefully as soon as possible in a few months. So that's my brief report.
So I know I couldn't hear Wendy. I don't know if anybody else could, but I assume that I'm next. So I'm just jumping in. I assume that's what you're speaking to. So this is going to be a very brief update because I'd really like to get to Dr. Lombard's presentation. Just an update on Incline Village Community Hospital. That hospital is doing very well. Our staffing is fine. We are getting the supplies in that we need there. As you know, we are not admitting COVID patients to Incline at this time. Our goal is to be, if Tahoe Forest gets full, that we would transfer patients to Incline. So that hospital is doing very well. Tahoe Forest Hospital, Harry briefly talked about that. Today I believe we have 7 positive patients. We have expanded our bed capacity at Tahoe Forest Hospital. We usually have 25. We have expanded that to 32. Last weekend, 2 weekends ago, we did see an uptick in our inpatients. So we decided to go ahead and expand our inpatient capacity, which California allows you. And that's really just adding 7 beds to our medical surgical unit. For our testing for both Tahoe Forest Hospital and Incline Village, we continue to provide both at both locations our Abbott ID Now, which is a point of care testing. We provide that in the respiratory illness clinic and the emergency department for symptomatic patients. The turnaround time of that is about 1 hour, 1 to 2 hours. And then the BioFire, which again, we were able to receive at Incline and Tahoe Forest Hospital from donations. That we are busy using that also for patients. That is the 22 respiratory panel. So it allows us to differentiate between COVID and potentially flu or other respiratory illnesses. And we are actively probably running that 8 to 10 times a day. Additionally, we do send some of our testing down to Renown because I think we do about 60 tests a day between the 2 hospitals. So it is been busy. And I just wanted to comment lastly that we continue to provide all of the services at both hospitals. Any change to that will be really dependent on staffing. you know, in order to provide the services, we need to have the staff, and we do have staff that we have to quarantine from exposures, or those that have been positive through their social distancing outside the hospital. So we do monitor that daily, but for now, we're able to continue to provide all our services. Thanks.
Thanks, Judy, very much for that update. Now we'll turn to Dr. Tim Lombard. He's an internist and cardiologist here at Tahoe Forest Health System, and he'll be reviewing the differences between COVID-19 and the seasonal flu, signs, symptoms, self-care, when to seek medical evaluation. So Dr. Lombard, welcome.
Thank you. So for those of you who don't know me, I'm Tim Lombard. I've been here for just under 40 years. And not many people know that when I came here in the 80s, we actually practiced in Incline when the hospital first opened there. And we had quite an active inpatient census with an ICU. And I spent a lot of time there. Fortunately, I was single because I lived half the time in Incline and half the time at Tahoe Forest Hospital and not much time at home. But anyway, that went away in the late 80s. And since then, I've been practicing in this community, and it's been just wonderful. So I'd like to share with you some things, and let me get it set up here on, hopefully this is showing up on everyone's screen. Just some points on flu, particularly as it relates to the context of coronavirus. To start with some very basics, everyone can see this, it's showing up? Okay, great. So the most common symptom of flu is fever, and then a variety of systemic symptoms, headache and sore throat and cough and whatnot. What's missing here are muscle aches, which do show up on this one. And this is comparing flu with cold, which for treatment purposes sometimes can have some relevance, because of course we do have treatment for influenza that is used selectively, and we still don't have one for the common cold, although it is largely a coronavirus, by the way. So maybe we'll learn something more about it as a result of this pandemic. So fever is much more prominent in influenza and kind of minimal with colds. Headache, muscle aches, and so on, kind of rare for colds. Colds also don't last very long. People tend to get over them pretty quickly, and the duration of infectivity is also much lower. Then if we go on to the more interesting and timely comparison between influenza and COVID, the first thing that we have to say about this is that at least 20% and maybe quite a bit higher cases of COVID are completely without symptoms, and those people still are unfortunately contagious. So all of these comparisons have to be considered in light of that. The most, do you see my my pointer? Great. So the most interesting symptom, and also the one which is most specific, certainly not the most common or sensitive one, but the most specific for COVID, is the loss of taste or smell. So it's one of the first questions we tend to ask people. And if we get a positive on that, our antennas go way up in terms of how much we have suspicion of COVID and get into testing. Shaking chills, much more prominent with this as well. Other things are more common with COVID, but still probably not enough to really allow us to differentiate. People oftentimes get sicker with COVID. However, there is the possibility when people seem to have something that is a viral illness or a flu-like illness and then seem to be getting better with it, there can be a late manifestation of a bacterial pneumonia complicating influenza. So the way this works is that if somebody gets the flu, they get a little bit sick, and then they start getting better and better, and then all of a sudden, it seems like it comes back with a vengeance. And that is often an indication of a secondary bacterial pneumonia. And the way to think about that is that the virus creates the mucus, and then the bacteria can flourish in the mucus and cause a pneumonia. Well, that's important because that's very similar to the time course of when people have a bad case of COVID. Many people have a mild case, they get sick, maybe they're sick for a week and then they get over it. But in some people, this late cytokine storm business, and this has gotten a lot of notoriety, you probably have heard this term before. It's a situation in which after the virus finishes replicating, the body's reaction to the virus creates a lot of chemicals that really make us sick. It's kind of like sepsis in that regard. The body's defenses are almost worse than the infection and can cause respiratory failure and many different types of organ dysfunction. So for people who are isolating at home and watching what's going on, it's important that if they start getting sick again, that they get in touch with a provider or the respiratory care clinic or somebody who can give them good direction as to how to handle that. In terms of people who are at high risk for severe illness, it tends to be similar in both situations. There is a difference, however, with children, which is interesting. We know that children can get pretty sick from the flu, whereas children don't usually get very sick from COVID. Their role is more as transmitting. Although there is this rare illness, unfortunately, which can make children very, very sick, this multisystem inflammatory syndrome, which is similar to some other things that kids get, which really makes them critically ill, but fortunately not common. How it spreads, similarly, mainly by droplets and coughing, although to some extent with hard surfaces and hand-to-hand and to other hard surfaces. COVID seems to be probably on average about 3 times as contagious as the flu. The R value that you hear about sometimes in the news is about 3 times higher for COVID. And that's probably what leads to these super spreader events that we hear about and see about. As far as when people start to become contagious, and in the flu, it's typically about 1 day before symptoms, whereas with coronavirus, it can be 2 days and sometimes more than that. And so this is why it's such a sneaky and deadly problem, because people can be walking around without symptoms or before symptoms and still transmit the virus to lots of other people. And that's what we're seeing right now with everything taking off. As far as diagnosis and testing is concerned, other than the specific symptoms that we talked about earlier, it really takes a test to be able to differentiate flu versus COVID. And that's why the BioFire test that Judy was alluding to earlier has been such a great help, because it tests for not only these 2 things, but other viruses and other bacteria and respiratory pathogens. So for the folks who are coming into the emergency room sick, running a BioFire can really help us decide who needs what, who needs antibiotics, who needs antivirals, and so on. And we can talk a little bit about antivirals later. As far as the type of flu tests, PCR test, which is highly accurate for COVID, is also quite accurate for influenza. The rapid antigen test, which is what you're likely to get at a provider's office or urgent care facility or something of that kind, unfortunately is not as active, it's not as accurate. So it may only pick up 70%, and that's at most. And sometimes it, depending on how it's collected and so on, the sensitivity may be even less than that. So oftentimes we find ourselves making decisions based on clinical characteristics and not relying totally on the test. In terms of prevention, I'm going to go straight to this somewhat busy slide, but let me walk you through this. This is pretty interesting stuff here. So this is the trajectory of flu over a number of years, and these are the previous 3 seasons. And we see that it starts in the fall, peaks at the beginning of the year, and then drops off very slowly with a long tail in the spring. This year, when everybody got serious about social distancing and shutting down, we saw something different. We saw the flu just plummet. Within a couple of weeks, it was just gone with almost no tail. So this is a great lesson as to how dealing with COVID can also prevent flu. And we were discussing early on before a number of people got on as to what kind of a flu season are we seeing? And you don't really know until later in the year, but the early indications are that maybe the incidence of flu is about half or something in that neighborhood compared to similar times of year in previous seasons. So hopefully we'll continue to have a markedly reduced flu season as well. And that's important, of course, because anybody who's got any kind of a respiratory illness takes up some attention and warrants attention. And so the more colds and flus and other kinds of things that we can prevent, including adult whooping cough and all the rest are really helpful. So it's important for us all to get vaccinated against all of those things, as well as our pneumonia shots. So an early estimation of flu vaccine was 69%, which sounds great. But after reevaluating the testing techniques in more recent years, unfortunately, we have a not quite so rosy picture of how effective flu vaccines have been. And it's interesting that, and not unexpected, that children do get a better response from the flu vaccines, but adults still do get some. Every year, the CDC and the manufacturers of flu vaccines have to guess what's coming based on what's been going around, what's in Asia, what's in the Southern Hemisphere. And some years they guess better than others. We are getting some better techniques at doing that. But we are also looking at some improvements in flu shots. This is one that's been around for a number of years now, the high dose flu, which is approved for folks over the age of 65. And the overall efficacy, this was published in the New England Journal back in 2014, showed a 24% improvement in the take of the flu vaccine. In that particular study, there weren't many people that got the flu in that population, interestingly enough, but this was the standard and this was the high dose. But if we take that 24% improvement and apply it to a population where the incidence of flu is much higher, that 24% relative improvement would translate to a very large number of people protected. There's reason to believe that if you look at the same strains, that it's probably even better than that. And that is addressed by this fact right here, the fact that the high dose flu is now available in the quadrivalent form, which means 4 strains. When it first came out, it was only available in the trivalent form, whereas the standard was quadrivalent. So you only got 3 strains instead of 4. So that's a considerable improvement. The other one is the addition now of adjuvant. This is now available, and the hospital's system has this. We don't yet know on the basis of outcome studies how much this helps. Adjuvant is something that is a way to improve the way that the antigen or the part of the virus that stimulates the immune system is presented. And so that adjuvant is believed on the basis of a lot of preliminary data to really help, but we'll have to see based on some outcome data as to how that translates into the real world. As far as contagiousness is concerned, as we mentioned, typically it's not very many days from incubation to symptoms where you will be transmitting the flu without symptoms. Unfortunately, with coronavirus, that's not such a happy thing. People can be walking around without symptoms for long periods of time. But with influenza, typically you can remain contagious for 5 to 7 days. And in children, there have been some cases reported beyond that, but usually it's a week. Once the systemic symptoms like the muscle aches and the fever and so on settle down, most people at that point are not so contagious. So usually a week will do it if you want to really be careful, especially if you have a severe case. Then a longer period of time of isolation and quarantining might be better. Of course, masks are a major part of public health prevention of viral diseases, and they've been used in other countries, particularly Asia, for a long period of time, since they had greater issues with prior versions of both flu vaccines and coronaviruses than we have had. The N95 seems to be highly effective at preventing its wearer, filtering out 95% of airborne particles. In terms of surgical and N95 masks, we do see that their ability to prevent viruses from exiting an individual are highly efficient. And this is where specifically the surgical masks are important in terms of everybody wearing one, because as we've all heard before, my mask protects you and your mask protects me. The fact that I'm wearing a surgical mask helps me somewhat, but it helps me more if you're wearing one. So we all need to be watching out for ourselves and our neighbors and encourage masking to really put the kibosh on this epidemic. Treatment for flu, we do have some antivirals. The most commonly known one is Tamiflu, and there are some others. There's an inhaled one. There's another one called Xofluza. And there are some other older ones that really have limited use. The current flu strains are largely resistant to them. There's some controversy about how effective these antivirals are, but I think the consensus is that it shortens the duration of illness, not by all that much, but maybe up to a couple of days, but it does seem to reduce virus shedding, so that has pretty good value. And in certain complications, high-risk individuals, it may actually have a mortality benefit, and that's certainly worthwhile. Really not any important adverse effects. A couple of people will get some gastrointestinal symptoms, but it's usually none or mild. Target populations, people who would seem to get the most benefit, similar to the population for whom concerns exist regarding coronavirus. As the age goes up, the risk goes up. Pregnant women, we all know what a bad disease that is, right? Residents of long-term care facilities, certain minority populations, obesity, folks who are on immunosuppressives, people who don't have a spleen, people on long-term steroids, and so on. So these are the individuals who are likely to get the most benefit from having the antivirals. As far as prognosis is concerned, death rate in the US is quite low from flu. Again, as we get older, it goes up. Some of this is related to age, and some of this is related to the fact that folks in this age group have more comorbidities. Very different in COVID. Numbers go up as we get older. This is not the most recent data. We'd like to think, as Harry alluded to earlier, that we probably have, as a result of more tools in our toolbox, some reduction in this, and we are seeing some improvement in mortality rates, and hopefully that will continue to be the case. So that's all I was going to say about flu in particular, but I know there was some interest in talking also about COVID. So I'll just jump right into PCR tests. These are the PCR tests, and this includes, by the way, the BioFire. The numbers over here on the left are the numbers of viral units that you need in order for the test to become positive. So these are pretty low numbers per milliliter. Not that we're trying to make microbiologists out of everybody, but then if we progress on to the molecular tests, and here's the Abbott ID now, here we're up to quite a bit higher, 300,000. So you can see that these are orders of magnitude higher. The saliva tests turn out to be pretty useful, and we'll probably see a greater role for saliva tests because of the ease of getting it. People are more interested in spitting into something rather than having a swab put into their way back into their sinus cavity, and it can be done more reliably at home, whereas the swab test probably is somewhat operator dependent. Here's what happens to viral illnesses. And we see that the viral loads start here, starting at day 0 exposure up to day 14. I don't know who the heck's trying to call me, but it's not the hospital. So the viral load after a period of time really starts to take off rapidly. And this period of time is the most crucial when folks are not having much in the way of symptoms and the viral load is increasing rapidly. And so here's typically what would happen with a PCR test, and then with a rapid climb not too long after, even though these tests are not as sensitive, the rate of rise of the virus is so rapid that it may be only hours or half a day or something of that the lower sensitivity test would become positive. So it's some epidemiologists feel that doing rapid tests day after day in sequence is another way to identify folks if these become in short supply. And then we have transmissible virus for this whole period of time out to 10 days for standard sorts of infections. We were discussing on a meeting this morning the latest CDC recommendations that suggest quarantining out to 14 days because there are probably a small number of people who can have virus out that long, especially folks who are pretty sick. And in fact, the sickest folks may have virus particles out to 20 days. The test, unfortunately, can detect virus particles and be positive even if we're not contagious. And that's what this indicates, that the tests are positive out here in most people, even though most people are getting over the virus by 9 or 10 days. But still, at this point in time, the CDC, out of an abundance of caution and really well-advised caution, has us quarantining out to 14 days because we really need to be doing the right thing given the dramatic rate of rise of COVID. So I hope that that's not too technical, or my explanation wasn't too convoluted. So hence the newest recommendations, which really confirm the older ones from the CDC. There's some discussion about maybe some people can quarantine for only 10 days, but that's not optimal, let's say that. And it does expose people to risk if we try to shorten it. And here's what happens if we don't do anything. Probably most people have heard about this or seen some of this data, but it's quite dramatic. What happened after August here, estimated that in September that roughly 20% of the cases in the United States were traced back to that event, and cost the United States about $12 billion. So this is what can really happen when this virus takes off. And unfortunately, we're seeing that now from a variety of sources: cold weather, Thanksgiving aggregations and such. So as we head into the holiday season with Christmas, it's ever so important that we take measures to not do that again. In terms of treatment, the first thing that showed up that really had great promise was dexamethasone, which is a steroid. And this has really shown more than any other drug that we have a reduction in mortality rates. It has a very specific use, not early on, because this is an immunosuppressive. So you don't want to give it to people early in their illness when the virus is replicating. You don't want to suppress that immune response. But later on, when the immune response, the virus is no longer replicating and the immune response has really run wild, this is a way to calm it down and decrease complications and mortality in that late cytokine phase. And so it really has shown itself to be of benefit, but should not be used in people who are asymptomatic or early in the disease. Then it can be counterproductive. And then the antivirals have come out. There were some other antivirals that have been developed for HIV and other viral illnesses that have been tried. and haven't really panned out. But remdesivir did seem to promote some some help in the virus, and it was the first one that really did. There have been 2 large studies of remdesivir, one by the National Institute of Health and then one by WHO, and they were a little bit different in their conclusions. They both show that it probably reduces to some extent days that are spent in the hospital. The study in the NIH group showed a probable mortality benefit. The statistics are a little tricky, but probably a mortality benefit in a select group of people who are oxygen dependent. WHO did not find that, but they didn't specifically really look for it. So there is some conflict. WHO's point of view is also a world socioeconomic point of view. So their recommendation is actually not to use that drug. And most of the folks in this country think that it is worthwhile because anything that you can do to reduce hospital days is worthwhile. And that's going to be ever more true as this pandemic increases and hospital beds become hard to come by. Monoclonal antibodies, there are now 3 of them that we have available to us at our hospital. They have a bunch of unpronounceable names. We call them the B drug, the C drug, and the I drug. And we are just beginning to use them. Last week, we treated a handful of patients, and we are still working out the details of how to get this done. This is strictly for outpatients, does not seem to help inpatients, but they're thought to be worthwhile because what has been shown is that they reduce the numbers of individuals who test positive and have symptoms and have mild to moderate illnesses, reduces the number of those folks who are going to end up being admitted to the hospital. So again, great value as hospital beds become few and far between, and anything you can do to keep somebody out of the hospital is certainly worthwhile. Vaccines, there's so much in the news about vaccines. I probably don't need to get into too much. As we speak, the FDA is meeting and in the process of developing their emergency use authorization. Probably starting next week, we'll begin to see some actual vaccines hitting the area. And in terms of distribution, it goes from the state, or from the feds to the state to the county, and from state to state, the tiers and the specific distributions vary somewhat. But for the most part, it looks like folks who live in communal settings, extended care facilities, and so on are first on the list because this is such a vulnerable population and a facility type of situation that can spread like wildfire. And then goes from there to frontline health workers, the folks who are taking care of those people, emergency room workers, ICU workers, and so on. And then from there to other critical workers, and then to other high-risk populations, and then finally down to the general population. There's a slight difference from what I can see so far in the state priorities between Washoe County and Nevada and California. And I think Judy might be able to speak with that. She's part of this task force. Judy, you have anything you want to comment on there?
Well, I would just, I forgot to mention that, probably right now, one of our main focuses is the COVID-19 vaccine. So in the state of Nevada, Washoe County Incline Village Community Hospital, Washoe County is working with Incline on that vaccine. It will begin with our frontline healthcare workers. If the FDA approves that December 10th, we are expecting to receive it at Incline the following week potentially. And the county is actually in Nevada. The counties are actually managing that process. And so they're giving direction to incline. And again, there is a tier system for the state of Nevada. We've actually only been given really the detail of tier 1A, which is again, the healthcare workers. And then we do know that eventually we'll follow based on federal comments. You have the tier, supposedly 1B was just related to, as Tim already talked about, ages and comorbidities, and then a phase 2, phase 3, phase 4. We anticipate, everyone will be able to have the vaccine sometime by the beginning of June. That's what we're being shared. In the state of California, the direction is a little more general and coming a little more slower. But the guidelines will be by state. So in the state of California, again, tier 1A is the frontline healthcare workers. And again, we anticipate receiving that end of a week of the 14th, and then beginning our immunization process following that based on the guidelines from the state. We'll be meeting with Nevada County to give us a little more clear guidelines for our tier 1A employees and physicians. We have not received in California much detail after that, same as the state of Nevada, in which 1B would be potentially again people with a higher risk, and then phase 2 maybe the teachers, etc. Then there's a phase 3, phase 4. It's will not receive any information regarding the medication itself and side effects until the federal government approves the vaccine December 10th. Once it gets approved, then they will share the information on the vaccine, which is the FETSR. That's the first one that will be approved. And then we will be able to disseminate that information to our employees and then out to the communities for those who want to make a decision if they want to receive the vaccine or not. The Madera, which is the second vaccine that will be approved, we anticipate that approval in about 3 weeks. We are fortunate at both hospitals. I will let you know the FETSR is the vaccine that requires the ultra low freezer. So at Incline, the county actually is holding it for Incline. We don't have an ultra low freezer, so they actually hold it for us, and then they'll bring it up when we're ready to use it. And then in Truckee, we do have an ultra low freezer that was housed in our cancer center. So we're actually able to have some of that medication on site. It's pretty high level information, but again, we get every day. Every day we get new information. Some of it's pretty limited, but we're responding rapidly to that. I would just mention for the community vaccine in Washoe County and in Incline, we are looking potentially to have a drive-through maybe up at Diamond Peak, and in Truckee to service both Placer County and Nevada County. We are working with the town of Truckee and the fire department and the airport to do drive-by there, so we can really respond, and then work with our local pharmacies who also will be receiving the vaccine. We really want to have a community effort in providing that to out there. So
thank you, Judy, for all of that information on the vaccine. And Dr. Lombard, that presentation was spectacular. Thank you so much. I do have a question, a few questions in the chat room. First is, there has been some speculation that there might be a fast antibody test from a drop of blood that is 95% accurate or thereabouts. Would you have any more information on that?
I'm not, don't have any information about that one in particular, but antibody tests in general have some significant limitations. First of all, the CDC's latest recommendations, the same document that they just released a couple of days ago recommending the 14-day quarantine, reaffirmed the fact that there's no really good information that tells you that antibodies provide immunity. And so we don't really know if those antibodies correlate with immunity, and if so, for how long. So it is not recommended that antibody tests be used for decision-making in terms of hiring, firing, walking around without masks, or anything else. And in fact, at our hospital, we have a policy of having people sign a waiver to that effect if they are going to come in and ask for an antibody test, and that does require a physician's order. So that's still the way things stand. We will undoubtedly have more information on that, and more information on actual so-called neutralizing antibodies, which are the ones that do provide protection. And it's still not clear at this point how long those antibodies, which are induced by the vaccine, will last. Obviously, because it's so very new. So there are a lot of unanswered questions. Another interesting aspect of the vaccine is that it may prevent you from becoming systemically ill because the virus is not going to go widespread. But there's concern that it might still live in the upper respiratory tract and you might still be contagious, even if you've been vaccinated and are immune to a serious illness yourself.
Okay, thank you so much for that. And then I did have another question regarding vaccinations. Would there or might there be some kind of registration for priority for the vaccine at some point?
I would assume so, and that's why I asked Judy to jump in. So as in terms of healthcare workers, those are people who are easy to identify. I'm a healthcare worker, but I'm not in the ICU, the emergency room. So, I'm not in that 1A tier. But once you start to get down to the general public, how will someone be identified who is at high risk when you pull up to a vaccine center? I don't know the logistics of how that's going to occur.
And I would concur with that. We're waiting to hear, again, we're hoping the states will provide us more guidance because they are hopefully in the 1B tier provide us more detail of who are priorities in those. And then again, how do you identify those individuals? We are planning to have a system where people can make an appointment. We want to make it, these medications don't last very long. Once they're out of the freezer or the refrigerator, you really have to use them within like 5 or 6 hours. So it's really important that we have a system in place that we make sure that people can come in, they can get their vaccines. And then, of course, you have to have a second booster. So within 21 to 28 days. So we do look for the federal government and state to really help us with that prioritization.
Thanks, Judy. Any other questions from any of the participants? I think then that about does it. I really do want to thank you all for joining us for this Lunch and Learn. It was your support, continued support is very appreciated. The foundation and the health system's appreciation is really limitless. We will be following up with a recording of this event, so we'll share that with you via email. If you'd like to go ahead and pass that on to friends or family, feel free to do that. It's always a good thing to spread education and information. And our holidays might look a little different this year, but we do wish you all a very happy, healthy, and safe season, regardless.
Thank
And
you.
thank you so much for attending. Thank you.
Hey,
Thanks, Dr. Lombard.
my pleasure. Thanks for having me.